Thank you so much for joining our briefing. Today on harm reduction is an essential part of a comprehensive strategy to combat the opioid epidemic. My name is Dr. Diana Fishbein. I'm a senior scientist and program director at the University of North Carolina in Chapel Hill. I'm also a part-time research faculty at Penn State University, and I'm the president of the National Prevention Science Coalition to Improve Lives. The briefing sponsor is the National Prevention Science Coalition. We're the first professional organization in the United States to transfer and translate knowledge and practices that have been amassed from the prevention sciences into public health policy. This organization has quickly grown to over 1,000 members with expertise from across the spectrum of disciplines that are relevant to prevention. And we work primarily at the national level, but also to some extent in states, to inform legislators and agency officials about the prevention science and its relevance to public policy. And we work with states and local communities to encourage the adoption of preventative measures that have been shown to work. Now I'd like to introduce Maddie Japina, who organized this briefing. Ms. Japina is a communications intern with the National Prevention Science Coalition, and she's a PhD student in communications arts and sciences at Penn State University, where she studies stress and coping in families. Maddie?
Thank you so much for that introduction, Dr. Fishbein. The purpose of this briefing today is to discuss the policy relevance of harm reduction as one of the strategies to address the opioid epidemic. Harm reduction is an effective public policy that helps protect people who use drugs from additional illnesses and injuries that may come from sharing needles, drug overdose, or avoiding medical care. Living with opioid use disorder, or OUD, presents obstacles to staying safe and healthy, as individuals often experience stigma from their communities and medical professionals, making it more difficult to obtain appropriate medical care, jobs, housing, and opportunities for a better life. Harm reduction strategies such as Narcan, stigma-reducing language, and medications that treat OUD can work to address these challenges. Today, we have some expert speakers on these topics, but first, I'm delighted to present videos from our congressional sponsors. Our first sponsor is Congressman Trone. Representative Trone from Maryland's 6th Congressional District is a strong advocate for combating substance misuse. He has led efforts to provide prevention, harm reduction, treatment, and recovery services to Americans with substance use disorders, and has a particular interest in curbing the use of fentanyl.
Hi, everyone. It's great to be here today with the National Prevention Science Coalition to talk about harm reduction strategies for folks fighting substance use disorder. As some of you may know, I ran for Congress to tackle our nation's mental health and addiction epidemics. My nephew Ian, he died of a fentanyl overdose in 2016. He was just 24 years old. Although we've been able to make some progress in this fight, there's still so much more work to be done. Tragically, nearly 110,000 died from drug overdoses in 2022. I co-founded the bipartisan Mental Health and Substance Use Disorder Task Force to form a coalition of lawmakers dedicated to combating these intertwined crises. Last year, we introduced over 100 bills to combat substance use disorder and mental illness, and 26 were passed into law. But one of the best ways to combat this epidemic is through harm reduction. Whether it's distributing Narcan or providing free syringes, harm reduction is an effective way to prevent people from losing their life and giving them time to get on the road to recovery. Studies have shown that naloxone can prevent 1 in 5 fatal overdoses if properly supplied. That's tens of thousands of Americans saved every single year, a game changer in this epidemic. In Congress, we're doing everything we can to deliver on these resources to the front lines, but we can't do it alone. I'd like to thank all the scientists here, policymakers, the educators, the advocates who make up this wonderful organization. We must always follow the facts, follow the science when it comes to policy, that's exactly what we're going to do. Thank you and be safe.
Great. And our second congressional sponsor is Congressman Tonko. Representative Tonko is from New York's 20th Congressional District. He has led efforts to increase mental health and substance use funding in the federal budget. And he's also advocated to make medications that treat opioid use disorder more available to people who need them.
Hello, everyone. I am thankful to join the National Prevention Science Coalition to Improve Lives for this important briefing on harm reduction. For those of you who don't know me, I'm Congressman Paul Tonko, and I represent the Capital Region of New York State. Thank you for your work and for bringing attention to harm reduction. I'm especially grateful for your focus on saving lives and recognizing the humanity in others. As some of you know, I have long recognized that addiction is a disease, and this disease of despair deserves a response rooted in hope. I do strongly believe that we must broaden our focus from arrests and incarceration to include those pillars of prevention, treatment, and recovery, including harm reduction. And as an engineer, I believe we must transform the way we think and talk about this issue. We must apply science and practical solutions that we know can work to intervene for individuals who find themselves on a path to addiction and those already in crisis, and to support these individuals and their families in finding a path of prevention or recovery. I'm especially proud of the recent success in my years-long effort to combat this epidemic with the passage of the Mainstreaming Addiction Treatment Act, or MAT Act. Signed into law by President Biden in December, this bill eliminates outdated requirements that prevented practitioners from prescribing proven addiction treatments like buprenorphine. And with the recent passage of the MAT Act, we now have dramatically expanded the United States healthcare system's ability to treat opioid use disorder with buprenorphine, increasing the number of medical professionals who can prescribe it for opioid use disorder from some 130,000 to 1.8 million with the removal of the X waiver. Last Congress, I also passed into law my Substance Use Prevention, Treatment, and Recovery Services Block Grant Act, which improved upon and reauthorized the program that serves as the cornerstone of states' substance use disorder prevention, treatment, and recovery systems. But we still have more work to do in order to protect the most vulnerable. Due to reduced tolerance for opioids and a lack of effective treatment options in our prisons and jails, individuals returning home from incarceration face an exponentially greater risk of overdose. In fact, studies show that former inmates are some 129 times more likely to die of a drug overdose in the first 2 weeks after their release than the general population. With this alarming data in mind, I teamed up with a bipartisan group of legislators to introduce our Reentry Act, a bill that empowers states to restore access to Medicaid benefits for incarcerated individuals up to 30 days prior to their release. By allowing inmates to receive addiction treatment and other services before returning home, this legislation will bring targeted treatment to those at this highest risk of overdose. Supported by more than 100 organizations from law enforcement to addiction advocates and public health and religious groups, the consensus is clear that this bill will indeed save lives, lower medical costs, and reduce recidivism. On the funding side, I helped lead the funding letter to support funding for the SUBG, or the Substance Use Block Grant Program. Along with Representatives Presley and Jayapal, I also helped lead a letter on the urgent need for securing sustainable and dedicated federal funding for syringe services programs and other harm reduction providers. Additionally, with the Biden administration's timely focus on harm reduction, I believe we have a chance here to act and save lives. That is incredibly important. So, as a co-chair of the Addiction, Treatment, and Recovery Caucus in Congress, and as a member of the Energy and Commerce Committee, which has jurisdiction over healthcare, I will continue this fight to ensure access to treatment on demand so that all those who are suffering from this awful disease can find help and can find hope. I hope that you will stay in touch with me so that we can work together on supporting those suffering with the disease of addiction. Again, I wish you a productive briefing, and it's an honor to be able to share some thoughts with you. Thank you again for allowing me to work with you as we move forward in attacking this crisis, a public health crisis. Good luck in all of your work.
And we, of course, just want to thank the offices of Representatives Trone and Tonko for offering their comments and their support to this really important briefing. I'm going to go ahead and introduce our first speaker now. So our first speaker is Dr. Robin Paulini, who is a professor at West Virginia University, and she is a substance abuse and infectious disease epidemiologist whose research focuses on mitigating the adverse health impacts of injection drug use. These include things like overdose, HIV, viral hepatitis, and serious injection-related bacterial infections like endocarditis. And she has also been the principal investigator of several grants funded by the National Institute on Drug Abuse. So Dr. Paulini, whenever you're ready, go ahead.
Thank you, Maddie. And I just want to confirm that you did want me to go first because that wasn't what I saw on the agenda. Would you like me to go now?
Yes, please, if you're able to.
Okay. Yep. Hold on one second. Good morning, everyone. Can you see those slides okay?
Yes.
Okay, great. Thank you. Good morning. I want to start my presentation by clarifying my own role in harm reduction. First and foremost, I am a researcher. And for the past 20 or so years, I've been conducting research on injection drug use, its impacts on health, and how people who use drugs access harm reduction and other health-related services. In my work, I collaborate directly with harm reduction organizations, both in developing my research questions and in conducting my research. Also, various times over the past 20 years, I've been a harm reduction volunteer. So I have experience with harm reduction, not just as a researcher, but as a person providing direct services. And while I'm currently based in West Virginia, I've worked and or volunteered in a variety of US states, as well as the District of Columbia and Mexico. Substance use affects health in a number of ways, but recent attention has focused on increases in overdose deaths. In 2001, around the time I started doing research on harm reduction, there were fewer than 20,000 overdose deaths in the United States. 20 years later, in 2021, the number was over 106,000, and final numbers for 2022 are estimated to reach almost 110,000. Over this same period, we've also seen increases in hepatitis B and C infections related to injection drug use, and injection-related HIV outbreaks in both urban and rural areas, including two here in West Virginia. We've also seen substantial increases in endocarditis and other serious bacterial infections that result from syringe sharing and use. So how do we turn this around, and what can science, research, and experience tell us about what we should do next? The 2022 National Drug Control Strategy makes saving lives its highest priority. And for the first time ever, the strategy acknowledges evidence-based harm reduction services as an integral part of this effort to save lives. The strategy specifically cites harm reduction interventions like syringe services programs and naloxone distribution as interventions worthy of federal support. That said, I want to take a step back and define exactly what harm reduction is, because as the term becomes more mainstream, I hear it being used in ways that aren't consistent with how those in the field define it. First, harm reduction is a set of practical strategies that we use to reduce the harms that can be associated with substance use. Generally, syringe services programs, or SSPs, serve as the cornerstone of harm reduction, providing sterile syringes to reduce the risk of viral and bacterial infections from syringe sharing and use. SSPs also distribute naloxone, the opioid overdose reversal medication, Many provide test strips for fentanyl and more recently xylazine so that individuals can test their drugs and make informed decisions about their use. SSPs also provide a wide variety of other services, including HIV and hepatitis testing, wound care, and linkages to substance use treatment and other medical and social services. Also under the umbrella of harm reduction or overdose prevention centers, or OPCs, which provide safe spaces for drug consumption. All of what I've just described relates to provision of services, but harm reduction is also an approach that meets people where they're at, both in the context of their drug use and literally in a geographic sense, without judgment. This suspension of judgment provides a safe space in which trusting relationships can be built with service providers. Harm reduction is also a philosophy. It provides space for individuals to define their own pathways to positive change and support them in those efforts, whether it's to inject more safely, to reduce use, or to stop using altogether. The scientific evidence supporting the effectiveness of SSPs is well established. Comprehensive review of the scientific literature published by the Institute of Medicine in 2007 concluded that SSPs reduce unsafe injection, and in doing so, reduce injection-related infections like HIV. They do this without harm to the surrounding community. SSPs do not increase syringe litter, increase the number of drug users, create larger or more risky drug use networks, or change local crime. The support received at SSPs can also lead to changes in drug use. Studies have shown that people who use SSPs are more likely than those who don't to enter substance use treatment, reduce injection frequency, and stop injecting altogether. This emerges both from the linkages to treatment services provided by SSPs and through building trusting long-term relationships with program staff that support positive change. And I want to be clear about this because many people think that harm reduction and treatment are mutually exclusive, that it's an either or proposition, and nothing could be further from the truth. Harm reduction can serve as a pathway to treatment, and harm reduction programs are there to serve individuals for whom treatment may not be available or effective, or who relapse, playing an important role in keeping them engaged in services to support their health. Despite the effectiveness of these programs, their reach is limited. The best information we have on the number of SSPs comes from the North American Syringe Exchange Network, or NASIN, which publishes a directory of programs. This is a screenshot from their website at nasin.org. The map includes 553 programs, but is not comprehensive. Also keep in mind that program size and services vary widely. Many of these programs have very limited service hours due to limitations in funding. So they may, for example, run just a couple hours a week. And you'll notice that large areas of the country don't have access to services at all. So what are the barriers to expanding these evidence-based programs? There are still some states where SSPs cannot legally operate. In states where they are legal, public opposition and local authorization requirements can be a barrier. Some states like West Virginia have onerous state licensure and operating requirements that make it challenging for programs to open and operate. Budgets are certainly an issue. A nationwide study of SSPs found that more than 40% operate on a budget of less than $100,000 a year. The most common sources of funding are state governments, individual donations, and nonprofits. 28% reported getting some sort of federal funding. In 2021, for the very first time, $30 million in federal funds was allocated specifically for harm reduction efforts. This is a welcome development, but it's not nearly enough to support the needs of existing programs or promote expansion. Finally, even where federal dollars are available, there's been a ban on federal funding for the purchase of syringes since 1988. This was extended to pipes and smoking devices in 2022. While SSPs primarily serve people who inject, providing smoking supplies facilitates transitions from injection to less risky methods of drug use, and also allows people who don't inject to engage in the comprehensive services that SSPs provide. More than 90% of SSPs distribute naloxone, as do a number of other state and local organizations. SSP-based distribution is especially critical since these programs serve those at highest risk. We know from research that the more naloxone that's pushed out into communities through SSPs and other programs that serve people who use drugs, the more we reduce overdose. Earlier this year, the FDA approved the nasal naloxone product Narcan for over-the-counter sales, which is a welcome development. However, harm reduction programs generally purchase a much cheaper generic injectable version, which remains prescription only. In effect, this sets up a two-tiered system in which harm reduction programs will still require a standing order or other prescription to access the most affordable form of the medication. Cost is also a concern for the public, as Narcan's manufacturer has not yet announced a price for the OTC product, only that it will be priced under $50, potentially putting it out of reach for the most high-risk individuals and their families. For all of these reasons, it's absolutely critical that we push for OTC status for all naloxone products so that programs and individuals can readily access the formulation that suits them best. Besides price, there are other issues that should be closely monitored as the OTC formulation rolls out. First, whether pharmacies will stock the product. Some naloxone purchase studies have found that many pharmacies have not stocked it as a prescription medication. Another is where it will be placed in the pharmacy, since stigma can be a barrier to purchasing items kept behind the pharmacy counter or in locked cabinets. Overdose prevention centers, or OPCs, also fall under the harm reduction umbrella. These centers provide a safe place for people who bring their own drugs to access safe use supplies and use under medical supervision. Like SSPs, they generally also provide a variety of other services, including HIV and hepatitis testing, linkages to substance use treatment, linkages to other medical and social services, and drug checking. There are as many as 200 OPCs operating in 14 countries, and their effectiveness in reducing the harms associated with drug use have been studied extensively. The most recent summaries of OPC effectiveness report that no client has ever died of an overdose at an OPC. In addition, studies show that these centers reduce overdose deaths in the surrounding community, reduce public injection, decrease HIV transmission, and increase substance use treatment engagement. Like SSPs, these sites have also not been associated with increases in publicly discarded syringes or crime in the surrounding area. There are currently only 2 sanctioned OPCs in the US, both in New York City, and Rhode Island will soon be launching a pilot program. Based on the existing evidence, further expansion of these programs in the US would save lives. Lastly, I want to touch on medications for opioid use disorder. These are generally viewed as falling under the umbrella of treatment, but some of the medications are extremely effective at reducing opioid overdose. Currently, there are 3 medications available to treat opioid use disorder: methadone, buprenorphine, and naltrexone. Methadone and buprenorphine are considered the gold standard treatments because of their ease of induction and their effectiveness in reducing opioid overdose. They're similarly effective in reducing opioid use and optimizing treatment retention. A recent study in a nationally representative sample of people with OUD showed that treatment with methadone and buprenorphine reduced the risk of overdose by 76% in the first 3 months of treatment compared to those not in treatment. A study conducted in Maryland found that among people in treatment for OUD, methadone or buprenorphine reduced the risk of fatal overdose by 82% compared to those receiving treatment without these medications. Yet, according to the National Survey on Drug Use and Health, only 22% of individuals with opioid use disorder received treatment with these medications in 2021. Other estimates are as low as 5%. Why is the number of individuals treated with these medications so low? There are several barriers at the systemic level that we can address. Regarding methadone treatment for OUD is limited to federally regulated opioid treatment programs, or OTPs. Currently, there are only about 2,000 of these programs operating in the US. And if you look at SAMHSA's directory of programs, you'll see that the vast majority are located in or near urban areas, making them difficult to access for people in rural communities. Historically, patients were required to present for daily observed dosing, with some exceptions. But during the COVID-19 public health emergency, federal dosing guidelines were modified to allow up to 28 days of take-home medication for stable patients and up to 14 days for some other patients. These changes were associated with improved patient engagement and patient satisfaction, with few incidents of misuse or diversion. SAMHSA has temporarily extended its policy allowing take-home doses while working on a more permanent solution, and that's a welcome policy development. However, the limitation of treatment to OTPs remains a barrier to expanding methadone access. Allowing office-based methadone prescribing would further increase access to treatment, particularly in rural communities where the average driving time to an OTP is estimated to be an hour each way. In contrast, buprenorphine can be prescribed in primary care and a variety of other outpatient settings, but historically has been constrained by federal requirements that mandated special DEA registration called an X waiver and set limits on patient numbers. The X waiver was eliminated under the Mainstreaming Addiction Treatment Act, or the MAD Act, which was passed as part of the 2023 Omnibus Appropriations Bill. This allows any practitioner with DEA Schedule III prescribing authority to prescribe buprenorphine without patient limits. I want to emphasize that this is an extremely important step towards expanding buprenorphine access. I do though want to mention a couple of things that will be important for optimal implementation of the MAD. The first is that we need more prescribers to prescribe to more patients, and the X waiver wasn't the only barriers of prescribing. Misperceptions related to buprenorphine effectiveness, stigma towards people who use drugs, and lack of institutional support for prescribing are just some of the barriers that continue to pass. Pharmacy dispensing can also be an issue. There's a growing literature on barriers to buprenorphine dispensing, with one study of pharmacies in 11 states showing wide variations in immediate availability of the medication. Other documented barriers include concerns about diversion risk, prescriber communication challenges, and concerns about DEA investigation. Multiple studies show that these barriers are more common at independent compared to chain pharmacies, a concern since the former largely serve more rural areas. And then the ability to prescribe buprenorphine via telemedicine is crucial, particularly for those living in rural areas. During the COVID-19 emergency, DEA temporarily allowed providers to prescribe buprenorphine without an in-person visit, and maintaining this fully remote treatment option is critical to. So there are two recent policy changes that are very positive steps in helping us to get evidence-based harm reduction services to the people who need them. These include the transition of Narcan to OTC status and the elimination of the X waiver. And then the two temporary changes that I mentioned regarding methadone take-home doses and telemedicine buprenorphine. But several challenges remain, which I've listed here. If we fully embrace harm reduction, the science tells us that we can substantially reduce overdose deaths. Positive steps towards this goal at the federal level would include pursuing parity in harm reduction funding, repealing the ban on federal funding for safe use supplies, supporting OTC status for all naloxone products, stating clear federal support for OTCs, liberating methadone from the OTP system, and making permanent the methadone take-home and buprenorphine telemedicine policies started under the COVID-19. Thanks very much. I appreciate your time this morning.
Thank you so much, Dr. Paulini. That was a really, really great presentation and very informative. So I'd like to take a moment to introduce our next speaker, who is Dr. Glenn Sterner. Dr. Sterner is an assistant professor at the Pennsylvania State University in Abington, and he is an expert on opioid use disorder and stigma. He sits on the Opioid Overdose Task Force for the state of Pennsylvania and is also a founding member of the Penn State Consortium to Combat Substance Abuse. And as well as that, he's the founder of the Share Your Opioid Story initiative.
Thank you very much for that, that welcome. I'm just going to share my slides real quickly. Can you see my slides fine?
Yes.
Wonderful, thank you. So as Maddie indicated, my name is Dr. Glenn Sterner. I'm an assistant professor of criminal justice and have really tried to work with our consortium on substance use and addiction to highlight the need for addressing stigma across the realm of substance use within our institution, but across communities and within the nation and writ large. We at Penn State also helped to develop our collaborative on substance use stigma reduction. And today I'd like to talk to you about stigma reduction as specifically as harm reduction. And so when we think about stigma, what we're really talking about is that we're referring to the negative process of being held in contempt or shunned because of collective disapproval. So basically, what we're understanding is that people simply are told that they are not worthy of respect, not worthy of connection to others, that they are said to be essentially separate from the rest of us, and that the rest of us are better than them. And so we typically see this in three different ways. First is that we identify social stigma. So this is the societal marginalization of a group. In this case, we're talking about those who use substances. We also see that from that societal marginalization, from those large messages that we identify, that individuals can then have what we call self-stigma. And in this case, what we're talking about is those internalization of those social messages, in basically indicating that I myself am not worthy of, for example, help, or that I am a bad person. And they begin to actually believe these messages that are perpetuated by our society. And then the third form is structural. And these are the policies and rules targeting a group of people, particularly that can then be discriminating against them, or may hold them back from participation in our society as a whole. And really, that structural area of stigma is where I believe that the greatest potential here for policymakers has the potential to reduce stigma more broadly. But when we think about stigma and substance use disorders, important here to note is that those with substance use disorders are more likely to experience stigma than any other mental health condition. And importantly, because of this, is that we know that individuals active in their substance use may be less likely to be offered help than individuals with other mental health conditions. And so why do we care about whether or not these individuals are being treated poorly, beyond the fact that we hope that, frankly, our friends, our family members, and our neighbors are treated well, both in terms of being in our society, but also as they seek help with their substance use issues. And it's because there are real impacts of stigma. And they relate directly to the way that individuals are seeking and gaining treatment for their substance use disorder. And so first, we know that stigma can actually create a lag in treatment seeking. So those who are actively working through their substance use and they then identify that they have an issue that they want to address, it can sometimes cause them to say, I'm not ready there to seek this treatment that is needed. I'm not willing to talk about my issues because, frankly, I'm worried that people are going to think poorly of me. And so we know that can then reduce their likelihood of, first of all, recovery, because it may increase their likelihood of overdose and, frankly, death from overdose. But more so, it can just prolong their substance use disorder more broadly. And so we want to make sure that we are getting people into treatment as early as we possibly can, particularly for those with a substance use disorder. We also know that from a systemic perspective, that there's a reduction in the quality of medical care that individuals receive as they go to seek treatment. There is significant stigma within the medical community, and we know that this is apparent because of several studies that have documented these issues, both from a provider perspective, but also from a patient perspective. And in fact, some of my work has identified that this through individuals who have sought treatment, that they have been treated poorly as they go to, for example, an emergency room, all the way to substance use treatment facilities. They are sometimes left out in hallways. They are asked questions that would typically not be asked questions of a non-substance use seeking and using population within a healthcare facility. And these types of experiences then decrease their likelihood of, first of all, coming back to seek treatment, and they also decrease their likelihood of being successful in their recovery process, because they may leave treatment early, or they may, frankly, unfortunately, simply just not be willing to work with these medical facilities into the future. We also, as Dr. Pelini just discussed, that there is a high underutilization of medication-assisted treatment, and the stigma attached to that treatment modality has reduced the ability for individuals to actually seek it out. We know that there is a distinct stigma towards the use of this within the systemic process of addressing and treating substance use disorders, both from a provider perspective, but also for those who are providing the opportunity to get access to those types of experiences, as Dr. Pelini just talked about. But even within the recovery community, those who would support those who are moving through the recovery process, we know that there is high stigma towards medication-assisted treatment, both from medication for opioid use disorder, all the way for those who are seeking treatment for example, alcohol use disorder. The recovery community continues to see this as an unfortunate non-pathway, and unfortunately we see this traditional reliance on solely an abstinence-seeking approach. Whereas we know that medication-assisted treatment and medications for opioid use disorder have the highest efficacy towards long-term recovery and fewer relapses in their process. And unfortunately, we continue to see that those who are seeking treatment are treated as separate, particularly when they are utilizing medication-assisted treatment. For example, in one of the studies that I've conducted, one of our respondents indicated that she noted that there was a participant in her fellowship process who identified as someone who was seeking and using medication for opioid use disorder. The individual stood up in the middle of their meeting, indicated that he felt that he didn't feel welcomed and that he didn't feel as part of that recovery community. He left those meetings and didn't return. She then learned later that he had passed away from an overdose from opioid use within mere weeks and months attached to that experience. And this is just one example of ways that we can work to make sure that we can educate folks on the importance of understanding the many modalities attached to recovery and recovery support along their pathway. We also know that those who are substance users also may become justice involved. And we know that there are stigmas attached to both being justice involved as well as those who use substances. And when those two stigmas combined, they unfortunately not just can create barriers for the individual who has been involved in the justice system. They continue to recur as they continue to be either released back into the community if they are incarcerated, or simply as they are working through their treatment processes. It can reduce their likelihood of being accepted into treatment experiences, and it can also reduce their likelihood of being able to achieve employment. We also know that within the criminal justice system, there are individuals who continue to recognize that there's a need to address stigma within practitioners within the criminal justice realm. For example, law enforcement officers, there are continued reports, particularly for those who are out in the communities, that they may not be willing to carry naloxone, and that there are those law enforcement officers who are unwilling to work with first responders to make sure that those who are using substances within our communities have their needs met from a health and treatment perspective, and believe that criminal justice and the criminal justice system is the most appropriate way to address substance use disorders within our communities, which we know is not the accurate way to get people into recovery. In addition to that process, we also know that because of the connection of criminal justice in professionals with individuals who use substances, that there is this concept of burnout. And because of that, they are reducing their likelihood for empathy over time. And so there is a need for continuously finding ways to support those within the criminal justice system, educate them, and find ways to reduce their stigma over time so that they can appropriately manage the situations in which they find themselves. And finally, we know that unemployment rates are roughly 15 to 35% higher among those who use substances and have a substance use disorder, and particularly those who then move into recovery. This is highly problematic. We know that providing recovery access to, support the access to recovery supports along their process is incredibly important if we are thinking about sustaining recovery over the long term. And therefore, in addressing these issues attached to employment will need to be continuously discussed, particularly within a workforce development perspective, and identifying policies in which we can reduce some of those unemployment rates and reduce the barriers for those who are seeking employment within our communities. And so there are specific steps that we can take in policy to reduce stigma towards substance use disorders. And the first is, frankly, to address insurance barriers towards medication-assisted treatment. Dr. Pelini specifically talked about other ways that we can think about medications for opioid use disorder. But we know that there are continue to be insurance policies that reduce the ability for those to engage in medication-assisted treatment, that there are some insurance experiences where they are able to refuse access to patients, and well, they are able to reduce their coverage of medication-assisted treatment, which we know is a significant financial barrier for those who are seeking recovery. And if we are working to address insurance and insurance coverages, we are likely to increase uptake and use of medication-assisted treatment, both for opioid use disorder, but frankly for alcohol use disorder into the future as well. The second opportunity for us to think through is workforce development policy change regarding disclosures. There is a large effort on the part of several folks within the recovery community to remove the check the box for those who have a criminal justice history. We know that those with a criminal justice history on an application, when they do check that box, that they are less likely to be called back for an interview, and that can increase significant barriers for individuals who are simply seeking employment. We also need to make sure that we think thoroughly through the way that we consider disclosures around substance use disorders, and we consider it a medical condition rather than something that is criminally connected, and that we need to make sure that those who have a substance use disorder have the right to make sure that when they do disclose, that they are not discriminated against, particularly for those who may need to continue their recovery support services. So for example, those who utilize fellowship type meetings and may need to get access to those as part of their treatment process, or for those who are trying to gain access to medications for opioid use disorder or medication assisted treatment along their treatment pathway and modality. Third, we need to really think about targeted education on substance use disorders, and particularly medication-assisted treatment, in order to make sure that we are thinking thoroughly about the concept of that issue of public-related stigma. We know that we can't take this on broadly across the populace, and that there are specific groups where those who are using substances may, again, encounter particular barriers. And therefore, those within the medical community, those within the criminal justice community, and frankly, those who are part of the recovery community may need to be targeted with educational campaigns, with particular education on specifically medications for opioid use disorder and medication-assisted treatment, so that we can reduce their stigma over time. And we do have evidence-based practice to show that there are opportunities to reduce those stigmas over time. When we combine education with personal experiences, we can find that those who have both of those in a combined manner reduce their stigma over time. And so we know what works, and we can replicate those over time. Which brings me to my fourth recommendation, which is specifically funding stigma interventions, both in terms of research and practice. NASEM, the National Academies for Science and Engineering, as well as The NAMI and several other national organizations have all identified that stigma is a significant barrier towards those who are seeking recovery services. Recently, I was able to listen to a phenomenal speech from someone from SAMHSA, who specifically has written largely about this. And when I asked the question about funding for supporting these types of intervention and this research so that we can increase our evidence for reducing stigma over time, the response was that there is really no coordinated strategy from a federal level in order to fund these types of experiences so that we can, again, reduce stigma in a comprehensive way as part of harm reduction practices across the country. And I find this, frankly, unfortunate and inappropriate, because the way that we have talked about stigma from a federal level, as well as all the way down to our communities, we know that this is a significant barrier and a significant issue that needs significant attention. And the actual funding that goes towards these initiatives is very small and, frankly, is uncoordinated. And so the more that we can do so in a way that could unite the NSF, the National Institutes of Health, as well as other funders at the federal level, the more likely it is that we are able to reduce some of these barriers in a fundamental way. And so I opened up this conversation indicating that stigma reduction has the potential to be harm reduction, but I fundamentally believe that stigma reduction is harm reduction. Stigma is producing harm among those who are seeking help for their opioid use disorder, and that is specifically creating harm for those who are using substances within our communities. And if we're really serious about making sure that we meet the needs of those who are addressing if we're really serious about meeting the needs of those in our communities in a comprehensive way, stigma reduction must be part of our harm reduction strategies, both locally, but also federally. Thank you very much.
Dr. Sterner, thank you so much for that presentation. It was great and really informative. I'm going to go ahead now and introduce our third speaker, who is Dr. Zilli Sloboda. So Dr. Sloboda is the president and CEO of Applied Prevention Science International, and she's an expert in substance use prevention and epidemiology. And she has served on the faculties of the Johns Hopkins University Bloomberg School of Public Health, the University of Illinois School of Public Health, and the University of Akron. So Dr. Sloboda, whenever you're ready, go ahead.
Yes, go ahead. Easier said than done. I don't know why I've got Penn State here. Okay, here we go. I hope. Come on. Sorry, everyone. Talking about technological glitches. Okay. Can everybody see that now?
Yes, very good.
Thank you.
Really.
Thank you very much for inviting me to this session. And I want to thank two presenters before me, because I think they sort of set the groundwork for what I want to talk to you about today. I want to talk about comprehensive substance use service delivery system. I think we're ready for that now. We know we have evidence-based prevention programs. We know we have evidence-based treatment programs. We have harm reduction services that have been demonstrated to be effective, if not embraced. And I think one way to address the whole issue of stigma is having a recognized comprehensive substance use service delivery system to address the individual needs of our communities across the country and around the world. When I'm talking about substance use here, I'm talking about all psychoactive substances, not just the opiates. I'm talking about psychoactive substances that are substances that impact and alter the functioning of the central nervous system. And I think it's really important to emphasize we really have the means to address alcohol use, cannabis use, etc., particularly amongst our young people. So my take-home points today are that the onset or etiology of substance use is complex. And because it's complex, it requires a comprehensive prevention approach. So I'm just not talking about harm reduction. I'm going to be talking about harm reduction in the context of the natural history of substance use. So like other health issues, our understanding of the natural history of substance use then highlights where the points are for successful intervention and support. I also am going to take an epidemiologic approach to defining the service need in any community. And this approach then suggests the need for a comprehensive system of services to address the effects of substance use for families, for individuals affected, and for communities. And that such a system of services not only saves lives and enhances productivity within communities, but ultimately is cost effective. When we talk, we have sufficient research now to show us that the causes for not only are this of substance use, but also other harmful behaviors that we engage in really is informed by the interaction between us as individuals, our genetics, our temperament, our physiologic setup, and our environments, our microenvironments and our macroenvironments. And that understanding this process also helps us identify points where interventions can take place to prevent the onset of behaviors such as substance use. And think about yourself. I often use, when I talk about etiology, I also talk about my brother and myself. My brother and I were so different, and our parents really had to parent us differently. And my brother had some problems in his course of his adolescence and into his early 20s. And years later, in our 70s, I asked my brother, wouldn't you have been better off if you had been parented by our grandfather? Because my grandfather and my brother were very much alike. And he said, yes, that would have changed my life. So think about that in terms of your own experiences with your family, as well as if your parents, your children all have different temperaments, for instance, and they require different types of parenting. So that has implications for prevention. I try to graphically present the natural history of substance use, looking at from the initiation of use to the continued use onto problematic use. And as you can see, there are different arms to this. So one can initiate use and discontinue use or continue use. And I'm sort of looking at the factors that play a role in the movement from one stage to the next. And you'll see that the color of these little balls is red is personal characteristics, green is environmental factors. Those would be the micro and macro level environments. And then, of course, yellow or gold, if you wish, are the pharmacological effects of the substance themselves, these psychoactive substances. So you can see that initiation of use from the epidemiologic information that we have that is related to the interaction between the personal characteristics and their environmental factors. But moving on to the continued use, the environmental factors play a little bit of a larger role, but we also are finding, of course, that the pharmacological effects of the substances begin to take over. And those pharmacological factors are growingly important in terms of moving from having problems or not having problems. What does this mean in terms of service need? if you think about what I just presented, the natural history of substance use disorders, we can see that there's a need for prevention, both universal, selective, and indicated. For those of you who are familiar, universal are broad, address broad risk populations, but also reinforce those who may even intend not to use substances in their future. Selective are those people who have more problems. You could be indicated, would be selective, could include children of substance users, and then indicated are those who have begun to experiment with substances and who would need different types of prevention services. And then, of course, there's treatment and recovery services, but you can see there's a big role for harm reduction in here. I also want to point out that we haven't talked about this yet, but we really, substance use is a chronic recurring health issue. And I think we do not treat it as such. Tom McClellan and his colleagues have compared substance use disorder to hypertension and to diabetes, all requiring obviously medical intervention, but also individual responsibility, and they need individual support is needed. Services are needed to give that support to individuals so that they take their diabetic medication, they take their insulin, that they monitor what they're eating, et cetera, as well as with hypertension. So we need to use that chronic disease model as a framework for how we talk about substance use. An epidemiologic perspective, then, given what I just said, then in any population, we're going to have 8 types of populations that require a variety of different services. So I sketch out here, I show these populations. There are those who don't use substances and are not vulnerable. There are those who do not use substances but are vulnerable. And those people require universal and selective prevention interventions. And we certainly have a wide variety of those now. Then there's the group that have initiated use and may not have experienced consequences of use. And those who do meet a DSM diagnosis for substance use disorder and need treatment but do not utilize treatment. And Dr. Sterner talked about that population. And there are those who meet a DSM diagnosis for substance use treatment who saw treatment but didn't receive treatment. And this is a very large population. We really don't have a good estimate or understanding of this population. But again, as both Dr. Polini and Dr. Sterner said before me, we really have information about them, that this is a large population that really needs to be addressed. And I don't think we're doing a good job on that. Then there's the people who received treatment and didn't complete treatment. As we know, dropout rates are quite high in some treatment programs. The other thing is, I haven't put in here is, and I should, is the fact that our information now is on the delivery of evidence-based treatment approaches leaves a lot to be desired in the United States as well as around the world. Then there's the 2 groups who received treatment and completed treatment and are in recovery. They also need treatment and harm reduction services. We need to protect them. And then those who receive treatment, completed treatment, and may have relapsed, and they need harm reduction services. So this is just my perspective. Many of you may want to take a different perspective on this, but I just want to put out there because we really haven't, I haven't seen anybody talk about a population-based approach to service needs. What does this mean? This graphic is an adaptation of one that comes out of the National Academy of Sciences, showing a spectrum of services for substance use, from health promotion through to maintenance and aftercare after treatment. I see harm reduction as, again, my perspective is harm reduction encompasses a good part of this service delivery system. So what would a service delivery system, Penny Fishbein and I have been talking about this for, I don't know, a year or so. And we actually published a paper this year on what we think a comprehensive substance use service delivery system would look like at the national, state, and community level. And this would include prevention, treatment, and harm reduction services that are delivered by this. And I think this is really crucial, is that they're delivered by certified prevention, treatment, and harm reduction professionals, and that the services that are delivered are evidence-based, and that these services are delivered to families, schools, workplace. I'm very happy that Dr. Sterner talked about unemployment in the workplace situations. We need to have more programs addressing the needs, substance use issues in the workplace. And then, of course, including health centers. The media is very important, as well as community, the environment in the community. And that could be a physical environment as well as social environments, such as really fostering non-use norms, particularly among adolescents. I think that having such a comprehensive system in place would lead to a reduction in cost to society for ignoring this approach to not only substance use, but also mental, emotional, and behavioral disorders, because we know that these disorders not only affect the individual, but also affect the others in the families, as I said, victim of crimes, peers, but also the community at large. I want to thank you very much for your attention, and I want to thank the National Prevention Science Coalition for involving me in this briefing today. Thank you.
Dr. Sloboda, thank you so much for that presentation and for being here today. I'm now going to go ahead and introduce our final speaker, who is Shannon Hicks. Shannon is a CCAR certified recovery coach professional, a harm reduction specialist, a smart recovery facilitator, a prevention facilitator for youths, and a dedicated advocate for medication-assisted recovery. She's also currently a full-time college student working toward a Master of Social Work while working part-time as a youth substance prevention facilitator. Whenever you're ready, go ahead.
So let me pull this up. All right, there we go. So I first want to thank the NPSC and Representative Tronan-Tonko for setting up this congressional briefing. I'm thrilled to be able to share my passion regarding harm reduction, recovery, and how stigma impacts those of us who have struggled or are struggling with substance use disorders. We'll go through a brief background about myself, my substance use, and my very long road that I took before I was able to get into recovery. I'll touch on the benefits of harm reduction and the negative impacts that stigma played in my life and in many of the lives of the people I work with. Growing up, like many people who have struggled with substance use disorder, I survived childhood trauma. Both my parents were divorced and remarried. I was sexually abused while I was a child. This caused me to be terrified of all men, my father and grandfather included. I also had a sibling that struggled with mental illness, and so this made my childhood one of being in a state of hyper alert. I was always on edge. I was always in fear. When I did drugs for the first time at age 12, I remember just how wonderful it felt. All my fear dissipated, my anxiety. I was happy and relaxed for the first time in a long time. I absolutely loved it, but then I spent the next 25 years struggling to find recovery. Like I mentioned, I spent my teenage years self-medicating. I went to my first rehab at 13, and I thought it was a joke because I thought all teenagers smoked pot, drank alcohol, did acid, smoked PCP. I now know that is not so, but because of this, I was just self-medicating. I ended up getting pregnant at 16, had my second daughter the day before I graduated high school at 8, or found out I was pregnant with her the day before I graduated high school at 18. By the time I was 19, I had 2 kids, a husband, and my first house. I was living what is considered to be the American dream. Shortly after buying the house, I got into a car accident and I was prescribed opiates for almost a year. My oldest daughter was diagnosed with a rare bone disorder, and my substance use quickly turned into substance misuse. When the doctor wouldn't refill my medication anymore, I started to buy them off the streets, and it wasn't long until heroin became a much cheaper option. As my heroin use progressed, I wanted to stop using. I tried detoxing numerous times at home, and that never worked. I'd been to numerous detoxes and rehabs, and I would get periods of sobriety, but not more than typically 18 months or so. I was avid that I could get sober if I went to meetings. And I had my daughter after a 9-month stint at a rehab. I was so excited because I thought this was the child who would never have to see her mother high. Unfortunately, I relapsed about a month after she was born. I kept trying to find recovery, but I eventually began believing what people were saying about me, that I was worthless, that I was a piece of trash. My family would be better off without me. I did everything I was told to do at the recovery meetings I went to. I had a sponsor, I led meetings, had service positions. One year I went to 342 meetings in 365 days, and I still relapsed. While not all 12-step meetings are alike, the consensus regarding medications for opioid use disorder in many of these meetings was if you are on methadone or if you are on buprenorphine, you are not sober. You would not be allowed to pick up medallions for various lengths of recovery. I would always inevitably relapse. And because I had done everything I was told to do in these meetings, I honestly believed I was one of the rare unfortunates. I was constitutionally incapable of ever getting and staying sober. I was doomed to die a worthless junkie, and my family would be better off without me. The shame and the stigma I felt from the recovery groups I had gone to fueled my substance use and my feelings of worthlessness and hopelessness. I thought I had failed at the only way to achieve recovery, and I was really just waiting to die. I didn't want to keep hurting my family, but I was hurting my family. I thought the only way I could stop hurting them was to be removed from their lives permanently, which almost happened a couple times. The shame I had felt for hurting my kids and having to keep my use a secret from those who could have helped me increased the feelings of shame and guilt, which increased my mental anguish, which then increased my substance use. In May of 2012, I had my first aortic valve replacement due to endocarditis, which is an infection of a heart valve. I'd never heard of endocarditis up until this point. I was asked if I did intravenous drugs, and I quickly denied that I did. I got really defensive. I said, no, I'm a soccer mom, not a junkie. My inability and my fear of being honest with my medical team set me up for increased risk of future heart infections because I was given a mechanical aortic valve. Being a mechanical valve, it is more prone to infections because it's considered a foreign body versus a pig valve or a cow valve. The one doctor who knew I was lying when I was denying my substance use rolled her eyes at me and was so cold and cruel to me after that encounter. This treatment reinforced the idea that it was too risky for me to be honest and ask for help. The stereotypes surrounding people with substance use disorder typically are not good ones. People who use drugs are generally considered to be bad people, unfit parents. And I was terrified that Child Protective Services would get involved and my kids would be taken away. And if I lost my kids, I knew I would not survive because they were literally the reason why I kept trying to find recovery. In 2016, I finally connected the dots regarding endocarditis when I got it the second time. There was no denying that this was a direct result of my substance use. I was rushed to Fairfax Hospital on my youngest daughter's birthday for emergency valve replacement surgery. The doctors came out to speak to my husband and told him he needed to prepare himself and our children that they would do what they could, but I probably would not survive. The MRSA had digested a good part of my heart. 13 hours later, I woke up fighting that, myself up so much because I didn't think I was worth saving. And I got so worked up that I ended up crashing, and I was incubated and placed in a medically induced coma for a couple days. I woke up as they were taking my breathing tube out, and I grabbed the doctor's arm and I said, if I am an IV drug user, you send me home, I'm going to die. I was immediately filled with terror. I knew there was no one saying what I had just told the doctors. And I knew the way I was treated was going to be directly impacted because I admitted my substance use. And that fear was justified. That night, I was in the ICU. I could not move my body. I could only move my feet, and I had to lift my head with my hands. And I had to use the restroom. And for 3 hours, I banged my foot on the bottom of the door, screaming for help. But I wasn't very loud because I just had the breathing tube taken out. When the nurse finally came in, she yelled at me, stripped me naked, and left me tilted a little upside down until about an hour before shift change. I was crying because I was in so much pain, and she said she was not going to give me any pain medication because I had done enough pain medication to last 3 lifetimes. I never saw the nurse after that evening, but I'll never forget that nurse. A few other horrible encounters with nurses and residents later really cemented in my mind that I had been correct all that time in not disclosing my substance use to the doctors. However, the surgeon who operated on me, I'm convinced he had someone in his family who was struggling with substance use disorder, as he was one of the only people who showed me compassion. And he treated me with the dignity and respect that I didn't think I deserved. But his kindness saved my life as much as the second valve replacement did. I was in the hospital for about 4 months, and they told me that they were going to wean me off of my pain medication and place me on buprenorphine. And I threw an absolute fit. I told the doctors I was not going to substitute one drug for another. My doctor told me, Shannon, if you want any chance to be a mother to your children and to stay alive, you will take the medication. Finally agreed, and I asked him how long I needed to be on the medication. And he said, with a history like mine, he would recommend 3 to 5 years, but if it were up to him, he would keep me on it for the rest of my life. And at the time, I scoffed at that idea. I was not going to be on it for the rest of my life. And I started plotting how I was going to taper off. My plan changed when I realized that buprenorphine was not what I had been led to believe it was. It was not a substitution for heroin. It was a medication that allowed me to learn the skills to get me through the hard times of my life. It got rid of the forever present desire to get high that had always plagued every other recovery attempt. Medication-assisted recovery allowed me to rebuild my life, repair my relationships, and be the mom I always wanted to be. Once this became clear to me, I started becoming an advocate for medication-assisted recovery. Being on medication doesn't mean you're not sober. It means you value your loved ones and your recovery enough to do what is best and do what will give you the best chance of survival. Another thing I would like to address is my dual diagnosis. I have severe ADHD, and for years this was acknowledged but overlooked because I was someone with a substance use disorder. Common adage is a drug is a drug is a drug. If you're addicted to one, you're addicted to all. While this has been debunked, as it was a saying created in the 40s or 50s, it is still held true. So I was unmedicated for my ADHD for a very long time. But people with substance use disorders don't have to go unmedicated. While medications should be prescribed with caution, it is not necessary to avoid them. I have been stable on Ritalin for over 5 years now, and it allows me to do things that were extremely difficult previously, like focusing on one thing, starting things and actually finishing them at the same time. So that's just a little tidbit I wanted to add it. But the consequences of stigma, many people seem to think that when people start working in the healthcare fields or any other occupation, that your preconceived notion and discriminatory thinking vanishes. People are people, unfortunately, and the only thing that can really battle stigma is educating those with preconceived notions. Studies have shown that people who have substance use disorders receive better medical treatment than those with addictions or people who self-identify as addicts. Now, that's something to think about. Both refer to the same thing, but the treatment of people with substance use disorder versus an addiction is greatly different. And a lot of this is due to the fact that stigma basically blames the person. It says that they're bad, they did this to themselves, they need to do better, and just must not really want to get sober. This then reinforces the feelings of being morally deficient and a failure, and fuels the negative self-talk and self-image that convinces the person who is struggling that they don't deserve to be sober or happy. These type of negative stereotypes are rampant in people currently struggling with substance use disorder, and the stigmatizing language and the horrible treatment of many people with substance use disorders in the medical field was one thing that really fueled my belief that my family would be better off if I would just die. I didn't think I could get sober because of all the stigma and labeling and discrimination I had faced. When we think about, well, why are people using drugs in the first place? People have found ways to change their consciousness since our ancestors crawled out of the trees, and we're going to continue to find ways to change our consciousness till our species become extinct. Some people do this through prayer, meditation, working, shopping, gambling, sex, working out, drinking. The list goes on and on. Those who have endured trauma, especially sexual trauma, are 26 times more likely to abuse drugs than someone without a history of trauma. They're 13 times more likely to abuse alcohol and are at increased risk for mental health issues. When you see someone who's struggling with a substance use disorder, instead of seeing someone who is a failure or who just doesn't want to change their life, try looking at them with a little compassion, seeing them as someone who is hurting and hasn't been able to find a healthier way to deal with their pain. It's amazing how much a little compassion can go a long way and make a difference in someone's lives. Which brings us to harm reduction. Harm reduction accepts for better or worse, people are going to use drugs, legal or illegal, and it tries to minimize the harms associated with prohibition and with substance use. This is done through educating the public about safer ways to consume substances and informing people about the harms associated with the substances they're ingesting. If we take, for example, today's heroin, none of it is heroin. It is all fentanyl, and a lot of it has xylazine in it. Public awareness and educating people who use drugs about the dangers are core aspects of harm reduction. Harm reduction realizes there's no one-size-fits-all to substance use or recovery. It's a misconception that harm reduction enables substance misuse, or harm reduction increases crimes. Evidence shows harm reduction programs actually can reduce crime and public disorder and improve social functioning and provide bridges to treatment. It isn't a one-size-fits-all. It's not harm reduction or treatment. Many times harm reduction leads people to treatment. The unconditional, non-judgmental interactions give the people who utilize harm reduction services a little bit of hope that maybe they can reduce their chaotic substance use and find a pathway of recovery that works for them. In Charleston, West Virginia, where I live, well, I live in Charlestown. Charleston is the capital. They shut down their syringe exchange in, I think it was 2019, and hepatitis C rates skyrocketed 300% within 6 months. West Virginia is experiencing an HIV outbreak as a result of intravenous drug use and the closing of syringe service programs, and nobody is talking about this. Harm reduction reduces HIV and hepatitis C by up to 50%. A lifetime of treatment can range anywhere from $100,000 to $400,000. Syringe service programs cost about $47 per person per year, and the return on investment is between $1.50 to $3.50 per dollar spent. Given all the positives with syringe exchange, we need to start utilizing this more so as a public health resource versus something for those people. We have harm reduction in other areas such as sunscreen, seatbelts, speed limits, birth control, cigarette filters. My favorite saying is, I don't promote drug use. I don't promote car accidents either, but I still think seatbelts are a good idea. Stigma and harm reduction programs Stigma and the lack of harm reduction programs contribute to numerous people dying every year because of HIV, hepatitis C infections, overdoses, endocarditis. As we know, over 110,000 Americans died last year as a direct result of opiate overdoses. These are people's sons and daughters, their mothers, their fathers, their sisters, their brothers. Most are genuinely good people struggling with a medical condition. If we were to treat any other medical condition the way we treat substance use disorders, people would be appalled. When someone gets open heart surgery to get a clogged artery opened, and the doctor finds them at McDonald's after discharge, stuffing their face with a Big Mac, They're not refused future treatment. This is not so with people with substance use disorders. I read an article in the New York Times saying 7% of people who get their valve replaced due to endocarditis survive the first year because they typically reinfect their valve and end up being placed in hospice care. Their valve is replaced, their substance use disorder is not addressed, and they are sent back out on the streets to white knuckle it. This is a medical condition. It needs to be treated as such, and it is not. And people are dying every day from preventable deaths. We need to stop having one standard for certain populations and have the same love, respect, and kindness for people regardless of their medical condition. We need to remove preconceived notions about harm reduction programs. We need to implement a federal Good Samaritan Law that provides immunity to people who use drugs together, so the fear of arrest can be removed if they call 911 to help someone experiencing an overdose. We need to lift the red tape and the silly, dangerous restrictions regarding the implementation of harm reduction programs. Medications like methadone and Suboxone need to be utilized over abstinence-based populations for most of the people with extensive histories of substance use disorders. We need to start judging people by their character and not the substances that may or may not be in their bodies. No one deserves to die because they use drugs. Thank you. And with that, I'll hand this back over.
Shannon, thank you as always for taking the time to share your story. I think it's really important and amazing and powerful. And I think that you really ended us on a perfect note with that quote at the end. We're at noon. So of course, people need to go their own way. Please feel free, but I think maybe we'll just take about 5 minutes just to do a couple of questions from the Q&A, if that's all right with everybody. So let's see here. We have a question, and Shannon, if you don't mind stopping your share, that would be great. Thank you. So we have a question from a participant that says, what role do peer navigators or people with lived experience serve in harm reduction strategies and stigma reduction? How do we lift these perspectives up without tokenizing them? And this participant also says, thank you for sharing your story, Shannon.
Being a peer recovery coach, I think that there's still, even in peer support specialists, a lot of preconceived notions about medication-assisted recovery and harm reduction. I think one of the main ways we can remove the stigma and educate people about the positives is to just do that. Educate people. A lot of people are scared of what they don't know. And harm reduction has always been that little boogeyman in the back. And there are so many misconceptions regarding harm reduction, recovery, who the people who use substances chaotically are, and the misconception that people who use drugs in any capacity have a substance use disorder. That's just not true. A lot of people can use substances and not have any issue with it. So I think education is going to be the main way we can break through the stigma and get more people involved.
Anybody else for that one, or should I take one or two more? All right, let's see. So we have a participant who's asking for some general thoughts and comments that most places in the United States, the goal is that substance use treatment is for abstinence. Many methadone clinics punish and involuntarily discharge people who have reactive screens for alcohol and drugs, as well as residential and outpatient substance use treatment programs focus on the goal of abstinence. We call people treatment resistant instead of asking what helpful help would look like. Just generally asking for some comments on those topics.
I think that the person posing that question is absolutely correct. And again, as Shannon said, we don't treat any other health issues that way, right? That you have failed treatment, it is your problem. We need to frame it as this treatment is not working for that person. What can we do better, right? And I think, again, it's stigma and a double standard that we treat substance use disorder quite differently than we treat other conditions. I completely agree.
I like to emphasize what I was glossed over a bit, was training of our service professionals. My experience with treatment professionals is they don't get enough ongoing training, and sometimes they get frustrated, they don't get support in their programs. And I think that there's turnover rates as well as negative attitudes about the people that they're helping. And years ago, I've been in the field for a very long time and done both treatment and prevention evaluations, and I've seen more attention being paid to this kinds of issues back in the 80s than we are today. And we know how to do treatment. We know what service providers are, with the attitudes, everything. I mean, we know how to do this, just like we know how to do prevention. Why aren't we doing that? Why aren't we getting support for that? And it's very frustrating. I think you can hear that in all of our presentations, that frustration is we just know what to do, and why don't we have the wherewithal to focus it? Why aren't we getting the support? And I think Shannon underscores this a million times. You multiply her experiences by what? Hundreds of thousands. And so we're not talking like thousands. And you're right about people who have hypertension, diabetics. We don't, if they relapse, we don't kick them away. We help them, we work with them, we get them counseling, whatever they need to be able to help themselves. Why aren't we doing that? So I think that's the message of this whole session.
The double standard is really heart-wrenching. My mom has diabetes, and she thinks she can eat that chocolate cake because she has the insulin in the fridge. And, I yell at her and I tell her doctor, and they just kind of chuckle. But if I were to go into my doctor and say, I went and did some heroin, but it's okay, right? I would get kicked out, and no one would try to see what the underlying issue is. It's not treated like other medical conditions. It's, we gave you your shot. And I think a lot of that is because there's still the undertone that this is a moral failing.
Shannon, you're right. And the thing is that we're working with a group of people to try and get that etiology model sort of integrated into training of treatment professionals, so they understand that what happens is not in you. If you're dealing with lots of frustrations and challenges in your life, and you're not getting the support along the way, and that impacts what you do. The other thing is, that's the other thing that I've noticed. And again, I don't know if Dr. Sterner and Dr. Pauline want to respond to that. The services that are being offered in treatment are limited. I mean, when you think about young people who start using substances, they basically have not gone through adolescence, and they need a lot of counseling. They need a lot of support services so that they can get be able to adjust their lives. You know, I really am dating myself now. In the 70s, when the treatment programs, they offered vocational training, they offered education so you get your GED. They even gave legal counsel to help with any kind of criminal proceedings. I mean, housing. To get people back on their feet so they become productive, contributing members of society. That's what we all want to do, right? We want to have families. We want to be good parents. You know, I'm really on a soapbox right now, but look at, why aren't we doing more parenting programs in treatment programs? So many of our people in treatment are parents, and they're going through recovery, and they now want to take on the role of being good parents to their kids, and we're not helping them do that. And it's no wonder that probably the highest risk group is our children of substance users. So we know so much now. Why aren't we doing it? All right, I'm off the soapbox.
I do think that's a really important point that someone just raised in the Q&A, which was that the drug supply is very different than it was in the past. When you remove someone from treatment, because they have imperfect, I'll say compliance, but they haven't met your standards for treatment, you're discharging them into a community that has drugs that are, the drug supply is full of fentanyl. And that's harmful. And so we should not be discharging people from any kind of medication assisted treatment, or I mean, it's a death sentence in a lot of places. So we have to think differently about that.
I like the term medication-assisted recovery because I'm in recovery, and I'm not sure if this is still the case, but I wanted to become a peer support specialist and was told that I could not because I was still in treatment because I was on medication-assisted treatment. So after that point, I started changing it to medication-assisted recovery because I consider myself recovered. I'm not stealing from my children. I'm not stealing from my families. I'm not doing all the things that I used to do when I was chaotically using substances. And a lot of people don't realize language has power, and things that we may not think of as stigmatizing triggers consciously or unconsciously the preconceived notions we all grew up with, that people who use drugs are bad and that they have a moral failing. So.
Okay, this is a great conversation, and I hate to cut us off, but I don't want to keep us on too much longer than our time. So I just want to, again, thank you all so much, panelists, for being here. It was really, really great to hear from you. You're all so expert in your fields, and it was just really great to have you all here. And we'll be working on getting the recording out and more resources to anyone who wants to have it. So again, thank you all so much, attendees, panelists. It was really great to have you all.